good afternoon, everybody. I think we're ready to go. Good afternoon. For those of you on the phone, I'm Misty Blackbear. I manage our Home and Community-Based Options and Person-Centered Excellence, or HOPE waiver, with the Division of Long-Term Services and Support. Thank you for joining us today for our Senior Link presentation regarding structured family caregiving. So just a little bit of background on the structured family caregiving service. So we just recently submitted submitted a HOPE waiver amendment to add 4 services, one of which is the structured family caregiving service. We were recently approved, so we can start the service as soon as August 1st. So we're really just wanting to get the information out to providers and others alike. We have today with us presenting on structured family caregiving, Senior Link. Senior Link is a provider in some other states that is the oversight for the structured family caregiving service. And they've offered to present this information because they are advocates of services across other states. So we'll welcome Senior Link. I'll have them introduce themselves, but we have Rachel and Jennifer.
Thank you. I'm going to stand really close to the laptop here. Oh, not right in front of that. So I'm Jen Crosby. I work with Senior Link. I'm the Director of Government Relations, and I'm here today with Rachel Richards, our Vice President of Government Relations. And like Misty was saying, we do this work. We advocate, for family caregivers and developing new supports for family caregivers, be that through a structured family caregiving-like model, be it through, say, other collaboration-like models that we might support as well, through technology, through giving caregivers some education and coaching as they go through their caregiving journey. So, we work with many states who are even just thinking about developing different types of caregiver supports, and this is, certainly one that we've been, excited to hear that South Dakota is moving forward with, and looking to support in any way we can. So what we'll look to do today is to walk through to introduce what the service looks like, talk a little bit about, really want to describe this as a new service option for participants within the HOPE waiver and their family caregivers. And we're going to go into some details about the characteristics of the model, how it's different, and then say, I'm right in the way if you're fine. How it's different from some of the other services that are already offered under the HOPE waiver, and then we're going to also, give you a little bit of a chance to kind of think about this in an open way and think about some of the participants and families that come in new to the waiver, and as you think about this model, what are some of the families that you work with that might that this might be a fit for. But that's more, as we walk through it, you'll kind of get a flavor for how the service works and how family caregivers engage, and it's going to be great.
Yeah, so sorry, Jennifer. One thing I did forget to mention is we'll have Senior Link go ahead and go through their entire presentation before we kind of get questions. So if you have questions throughout, go ahead and jot them down. We'll have a question and answer at the end of the presentation.
Great. Here we go. A little bit about who we are. We do provide structured family caregiving in other states, but Connecticut, Massachusetts, Rhode Island, Indiana, Ohio, Louisiana, and Pennsylvania, and Rhode Island, of course, I already say that. Also, I'd like to focus more on what I said earlier. We really do advocate to, engaging family caregivers in collaborating with their, the participants' full care team. And full care team being their physicians, other extended family members, LTSS specialists who engage with them when they are receiving HOPE waiver services. But what are the options? What are any of the options that are now becoming new for family caregivers? And this is one service that you'll see as we walk through it is just as much about supporting family caregivers as it is about supporting the participant. I should have said those in reverse, right? We support the participant first, and the caregiver is certainly the person providing that service. But as we walk through this, you will see this is equally about supporting the caregiver as well. So a little bit about why South Dakota's chosen to do this. We heard a lot from we read a lot from some of the, I think it was a state plan on aging and other surveys that the state had done, that they were looking to develop new service options for families, for participants who were, say, unable to access in-home care services, or just wasn't a great fit for them. So what are some other service options? So this is one of those where we will always say that there are many tools in the toolbox, many tools in the toolkit, and not every service fits for any participant who wants to enroll in a waiver or needs to enroll in a waiver. So this is one service option, and what it does is it really, I use the word leverage, but it uses existing resources that are close to that participant. Existing resources being their family caregiver, the one that they trust to provide care every day, the one that they live with, and it also allows them to choose the home that they want to live in. So they can stay at home, whatever their home is, for as long as they can, and they are supported by the person that is closest to them. South Dakota. So we know that this is just some general research that we've done about approximately number of caregivers in South Dakota, and so we look at this as this is the resource, right? This is the army that you have already providing much of the informal support to some of the participants that either are already receiving home waiver services, or many who are not yet. So what is it that we can do to support this group of people, these committed caregivers who are already doing much of the long-term care work that folks need? Let's see. Oh, I guess I didn't go through that one yet. So how is structured family caregiving a little bit different? I think I already talked about this a little bit. What it does is it allows participants to choose the home that they want to live in, allows them to receive care from trusted family caregivers, and we're going to walk through in a little bit how we ensure that those caregivers are qualified to provide the service. How do we ensure that they have the resources that they need to provide the service, and do it in a high quality fashion. What it does is it gives those caregivers the tools that they need to be able to do this over the long term. So how do you give them the education they need, the resources they need? How do you engage with them on a regular basis that gets them to open up in a very different way than they might if you're really only talking about the specific service that the participant is receiving? So you really want them to open up and share personal information about what they're going through as a caregiver. I would say, again, this is why the service is so focused on, again, supporting the family caregiver in a way that allows them to provide high quality service to the participant. So in general, this is how South Dakota has structured the service all in one slide. And we'll go through each of these components in more detail. So structured family caregiving, this is where a participant is receiving service from personal care service from a live-in caregiver who they live in the same home. The home could be either the participant's home or the caregiver's home, and that caregiver is receiving ongoing education, resources, and financial stipend from a caregiving provider for the care that they are providing to that participant. And there's an agency oversight role. So I use the word oversight in a fashion where we're ensuring that the participant is receiving the care as dictated on the care plan that's established by the LTSS specialist, and we're also wrapping that whole support around that caregiver in order to help them do that in a more effective way. Providers qualify the home, we qualify the caregiver. We are engaging with them on a regular basis, and how that happens from provider to provider, how frequently that happens, really dictates how that relationship is built. You don't want it to be too infrequent such that you're really only talking about the personal care specifically that the consumer is participant receiving, but also about, again, what I said earlier, what the caregiver is going through, and what are some of the resources and strategies that they need to continue to do this in their home. Provider agencies, we are assessing the home as well to ensure that that home is safe and accessible to the participant. We're doing home visits to, kind of checking on their homes, checking on their caregiver, and also engaging with those LTSS specialists to kind of give them some insight into what's going on with that participant and the caregiver on a more frequent basis. So, again, that communication is key with that caregiver, where we're able to receive insight into, are there hospitalizations that occur? Are there some triggering events that may warrant the LCSS specialist to come have an extra conversation with that family participant to see if the situation has changed, if the participant's needs have changed. When a caregiver again lives with the participant, provides daily care and support to the participant, and aside from the personal care, where we see this service certainly benefit for those families that are managing behaviors that are related to dementia. How do you help a family come up with those strategies that aren't provided to them in a generic way, but it's through that assessment of the provider, assessment of the home, assessment of the participant that allows the provider agency to really establish a coaching pattern for that specific caregiver for their specific needs in helping that one particular participant or two particular participants. So here's a visual for folks in the room and on Skype who are visual folks. So this is how Senior Link administers this model, where you have live-in caregiver and participant living in the same home. Caregiver provides the service and support throughout the day as the participant needs. Caregiver coaches, Senior Link calls them coaches. We are engaging with them through technology, we have a HIPAA secure web app and platform that we engage with them in more real time than, say, a phone call. And we also do that through in-home visits where we can spend some quality time with that family, go through some assessments, like some really structured detailed information about what the caregiver might need to continue to do this work. I'm flying through this, and I promise that we will have plenty of time for questions as we get through. So I'm gonna continue to walk through this really quickly, spend some time on some key points, and then we're gonna leave some time at the end to really walk through what some of your questions are. And as I walk through, you will see that I'll answer several that will pop up into your brain, but definitely write them down. We'll get to them as we go. So how South Dakota has defined caregivers within the home waiver. And I will stop here and say that these are some criteria that we've identified through the whole waiver itself, but there will be some additional criteria that likely comes through the supplemental agreement process. So qualified caregivers may be related or fictive kin, and fictive kin, as we understand it, are really folks who are known to the participant. So they could be friends, they could be significant others, they could be neighbors. So it's someone who is engaged with that participant in their life in a way and known to them in a fashion. The caregiver must live in the same home. So this is one of the key criteria for the service, where they live together. That caregiver is providing most of the daily care and support that the participant needs on a regular basis. They are required to pass state fingerprint background checks to qualify minimally for the service. The provider agency, this is where I'll pause a little bit and say, there is a role for the provider agency to really determine, aside from the minimum qualifications of that caregiver, caregivers are going to come in and be imperfect. We are all imperfect. They're not going to be fully trained as you would see a CNA staff or a formal professional staff coming into the home. We are meeting caregivers kind of where they're at. And so there's minimum criteria that is a requirement of the state, and then providers kind of take those assessments that they do up front to understand what are the caregiver's real needs on any given day, and how does that compare with the participant's needs. And so in terms of what that assessment process looks like on the first day, and then how you build that relationship over time, that caregiver is going to develop those skills over time as that provider works with them and provides coaching and education. Over the first 6 months, they will, at the end of the first 6 months, they will have a lot more information than when they first started. Caregivers contract with a generally with a provider agency, and they agree to collaborate with that provider agency on a regular basis. So this is another key component where you're having caregivers, if they're engaged in this program, we want them to communicate openly. We want them to feel free to share. Not only are we checking the box, these services have been provided to the participant on a regular basis, but how are they doing? How are they meeting stress and strain? If there is some, certainly there is some in doing this work over the long term. How are they able to share, where they're struggling with persistent behaviors that are happening in the home, and how we can help them, manage those behaviors, identify strategies for those behaviors, and then also how providers can take a look at the engagement that we're receiving from them on a regular basis, and how do we change how we coach with them? How do we change the resources? How do we look for trends that are happening within that home with that caregiver and participant, and kind of forecast what might be coming, say, a month from now, 3 months from now, or help that caregiver to kind of understand what's going on and what are some of the differences of behaviors. But I think I'm speaking ahead of myself again, so I'll go on to the next one. So there's a qualified home. So this is a private residence where the caregiver and participant live in the same home. The minimum criteria for the service would be that the home is accessible, certainly to the participant, that it's generally safe for the participant, it's where they choose to live. And again, there will be no more than 2 participants receiving structured family caregiving within this home setting. So there certainly could be other participants from the Hope Waiver living in the setting, but they might be receiving other waiver services, or there could be certainly other people living in the home as part of the family. One thing I would also say here is, the home may come imperfect as well, right? So you're helping a participant remain where they want to be, as safe as they can be, and over time identifying risks that are in that home, identifying trip hazards that might fall risk hazards that might be in that home, and working with that participant and caregiver to try to minimize those as best they can, and also working with LTSS specialists to identify potential referrals for ramps and say other services that might be needed in the home. So we'll jump in here to what is the provider agency's role in this. So provider agency, I think I've talked about this a little bit. We are, and again, there'll be more, this isn't all of the detail that would be for provider agencies. There'd certainly be more in a supplemental agreement when it's finalized. But one of the key components here, I think I've already walked through this a little bit, assessment of that caregiver, assessment of that home in a way that is, you're kind of partnering not only the participant assessment and what their needs are, but the caregiver's assessment. What does their informal support system look like? Is that caregiver kind of doing this on his or her own? And what are some of the stressors that might be coming in on a regular basis? What are some of the dynamics that we need to be mindful of? And how do we get that caregiver to really open up about what their needs are? Many times caregiver isn't going to come to that realization unless you really get them to open up in a very personal way. And that takes some practice to do that. I would also say that the coaching that we provide, while I say it's personalized and everyone uses that term personalized, it needs to continue to evolve as that caregiver is communicating with that coach, or the provider agency role that comes into their home and talks to them on a regular basis. As that caregiver is engaging more frequently, they're becoming more comfortable, they're going to let a provider agency know when they really can't handle if mom asks if the dog has gone out, the 17th time in the last 10 minutes. How do I redirect in a different way? Or how do I, they don't even know what the term redirect might be. How do we get them to open up in a very real way that isn't, they're not going to be ashamed of? The communication is key, the assessment of that caregiver is key, and it also provides, not only the coaching piece, but it also gives them a stipend to help keep house and home together. So if this caregiver is able to, say, was working part-time and is able to, primarily take on this role of living caregiver for someone who might have dementia, this stipend allows them to do that. And I'll talk a little bit more about why I use the term stipend. That's very much a legal term that we'll get to in a little bit. Some of those trigger events where LTSS specialists may not hear about, say, hospitalizations or that the caregivers had something that happened to them, that they somehow have fallen ill. How do we help them establish an emergency backup plan? How do we look to some of those informal supports to really begin to allow that caregiver to have a support system where they may not have felt that they had one before? And I think that's all. I think I'm repeating myself over and over. So our role, where we engage, the other piece of what we do is certainly engaging with LTSS specialists. And I talked a little bit about this with triggering events. But really there's a communication pattern that needs to develop with those specialists as well. Some specialists may, as they're been engaged with that family, maybe over a period of time, they have a sense of what that family needs and what some of the, are there lots of hospitalizations that have been occurring over the last, say, 2 years, and how do we establish a real communication pattern with that specialist that's meaningful to them? We don't want to over-communicate, we don't want to under-communicate. But what is it that we're bringing to the table? How are we allowing that caregiver to collaborate with that specialist in a meaningful way, be part of that, say, care team? So we're working with the specialist to develop some of those backup plans, look for any, say, other supports that might be needed in the home. I mentioned earlier, like ramps or possibly respite for that caregiver. We're also looking to, certainly we'll be reporting critical incidents as they occur. That's all I might say on that one. And so this is where, what is the benefit of structured family caregiving, and kind of thinking about this holistically. Who benefits from it in what way? Participants certainly are able to receive care from the person that they trust the most, the person they live with and receive care from every day. They're able, and that care is culturally competent because that caregiver who's living with them knows them, knows the food that they like, knows how they, prefer to be changed, what time they prefer to be, put in their clothing for bed, what are some of the activities they want to do outside of the home. That caregiver knows their life inside and out. So how the participant is receiving care from a person that they know the best, who they trust the best, and knows them the best. Caregivers, I'll make a note here, I've said multiple times, the service is as much about supporting a caregiver as it is about supporting the participant. So caregivers receive a financial stipend for the care and support they provide to that participant. They get some ongoing coaching from a caregiver. They have a resource that they can reach out to with general questions. We also help them engage differently with their physicians. What are some of the questions that they may forget to ask when they are at an appointment with a participant that they support? How do we, if they have smaller questions that they think are not, that they don't want to bother the physician with, but you can ask a specialist who may know dementia inside and out and has worked with them, so they're going to ask some of these smaller questions about what some of these behaviors mean. They have a resource that's available to them, a real person that's available to them that will help walk them through, how does a caregiver work through this, develop strategies over time. Providers are going to work with that caregiver to understand the progression of the disease of that participant living with them, how behaviors will change at nighttime, how to recognize changes in behaviors when someone with dementia has certain behaviors that are related to dementia, and there are behaviors that are related to UTIs, and how does this type of behavior warrant getting the caregiver to recognize that and then seek a physician appointment because they believe in UTI is brewing. So that's one example of how you're helping a caregiver understand what's in a different way, use the eyes and their experience with this participant and love for this participant to inform them and help them see kind of the changes that are happening over time. We're helping caregivers engage in part of the care planning process in a very different way. They come fully informed to help that participant stay home, and that's their primary goal. So how do we help that caregiver engage that, with LTSS specialists in a very different way as well? And certainly for LTSS specialists, we think we've heard from other waiver case managers in states that we support the service, that they're receiving relevant information in a timely fashion. And so they're able to, say, address changes in a participant's care plan needs more real time. So they're not waiting for a significant event to occur. Sometimes they're hearing about it from the structured family caregiving provider before a significant event occurs, or before they kind of hear from that caregiver when they're at the end of the rope, so to speak. So I'm going to pause here for a minute, and I know that I walked through about the structure. But when we think about the participants, the possible participants, or folks that you're thinking about, I'd like to see if there are any questions about the kind of the structure of it. And then we're going to get into some more detail about rates and a little bit. But first, does anyone? Sure. Yep. Yeah. So these are people who live in their own home in the state of South Carolina. Sure, they would, so the structured family caregiving provider, would they be located in the state, so to speak? Yeah. Sure. Yeah, there would be local resources to do that. I mean, if regionally located, I would imagine. Yes, we have, in other states where, Massachusetts, we have at least 8 branch offices, so regionally located. It would be a little bit different here, size and scope certainly, but yeah, they're all local people.
I'd just say about that, the key, right here, but the key is you're trying to establish a relationship, right? So people need to, they don't share with you their intimate details of their daily life if they don't feel like they know you, they trust you. South Dakota obviously presents some geographic challenges, and people can't always lay eyes on. And so that's in part why senior language does do some good things in states that have rural pockets. We've really tried to figure out what are different strategies, some ways that we can stay engaged. And, Jan referenced the fact that we use technology because who isn't using technology these days? Well, I use it with my kids. I can use it to stay in touch with my kids' coach as well. And, we have caregivers text us stuff that we post good stuff. We had a great day today and got mom out and for a walk in the park. And then we have, texts that we got into the middle of the night that say, we had a really bad night last night and, angry. And people just text to reveal stuff and they let us know and we can go in there and help. So it's all about the relationship and how best to build the relationship.
How do other states provide or get feedback from the oversight agency to ensure that you're doing what you're supposed to be doing as that provider? So that you're providing that training and support to that.
Sure. So,
can you repeat?
Sure. One of the questions for the folks on Skype was how does the oversight agency document or demonstrate that we are following the state's criteria, so to speak? We're in communication with LTSS specialists, so we are forwarding information back and forth, hoping that as specialists are able to share information with us that when they do a home visit, that we're able to then use to allow us to inform our assessments and our documentation. We certainly keep documentation, all of the communication that we do with them, even through the technology. Some states will have certainly records, assessment records that will be in all consumers, caregivers, home settings. There's also communication with doctors and nurses if needed, through that collaboration piece. We're also looking to, if that participant is able to access something like adult day health, is there a way for, does that caregiver coach also connect with the adult day health program to kind of understand if those behaviors are also seen, say, in the adult health program. So there is certainly documentation that providers must keep to underscore the work that they're doing to ensure that the participant is receiving the care that they need, for the waiver service, but also is the caregiver supported in a way that, makes all this kind of stick together.
Most states, in our experience, leave it to the provider and the waiver coordinator to sort of work out what is the frequency of communication that you want to have. Very few are very structured about that beyond incidents. But there is one state where we work where they've essentially developed a template for the basic information that you want you to share with us with a specified degree of frequency. It's basically a form that says, what do you know about the family at this point in time, and they specify. Is there something that you're thinking about that would make your life more a specialist or supervisor? Is there something that you're thinking about that would work for your staff?
Well, I was just wondering, about the risk of having the provider enrolled as an agency and then instead of the caregiver and then not follow through according to how we as the state know that.
Yeah.
What safeguards another something to check.
Well, a person from this service usually not be
Is there something that works for you with home care agencies that makes you have a good sort of staff feel like they have a greater degree of comfort?
Well, we have some, systems in place that, check to make sure that all the requirements of the provider agreement and annual visits and provider reviews and those kinds of things. I think that's helpful, and obviously we can't do that every day, but
But in some instances with the caregiver being family member, then that changes the dynamics.
Definitely a different dynamic, for sure. Yeah.
We have a question on the Skype as well. The question is, who pays for supplies like gloves, pads, cleaning materials, etc.? Just from the Hope Waiver management, we would expect that a consumer that needs some medical supplies, that would be a service that's paid for through the Hope Waiver. But I think what they're getting at is who would be responsible for like the cleaning supplies in the house. That would likely be the caregiver.
Right. So this is their home. So how are they, managing that today? And like you said, if the participant needs certain supplies, then those will be provided. In terms of the staff from the oversight agency going into the home, the provider agency would supply that to those staff during that annual home visit. But yeah, otherwise the arrangement would really be between the consumer and caregiver to come up with those supplies. And some of that is, this is a service that pays for care and support provided to the participant. We haven't talked about, so the participant and caregiver live in the same home. There is otherwise there is a relationship or a conversation that happens about how is room and board kind of considered in this, right? Does the participant, contribute somewhat to groceries and other bills for the household? So all that is a conversation that happens during this kind of, I don't want to use the word onboarding, but during this, this initial assessment process, so that all folks in the mix are kind of understand what their roles are and how they contribute. So, as we think about participants who work well within this model and caregivers that work well within this model, I would say, certainly participants who have an engaged family caregiver who supports them on a regular basis. If they have family members that are, say, expressing concern that that the participant has needs that are, becoming more chronic or more constant over time, and they need some more support. Are they demonstrating or kind of you're fearing a little bit of caregiver burnout that might be happening? you know, do any of these caregivers support people with Alzheimer's and dementia? And you know, to help them develop some of the strategies over time, because that is only going to, you know, certainly progress over time. And then I guess I would think about the folks in the room. You know, do we have any, as you've been hearing me talk about this and hearing me talk about the structure of it, and are any folks coming to your mind as you receive a call for a person who's newly enrolled in the waiver? What might trigger you to think about, say, of your options, why might this be a good fit? See, that's a statement, that's more of a question to you.
So we heard from the service coordinator in the session yesterday. You feel like the light bulb go off, and she talked about a family that she was working with where the family was very reluctant to have somebody that she didn't know, who wasn't known to the family, come in and provide support. So that's sort of an example of how you might think about folks who would be open to a new service model.
Right.
So really we throw this sort of big laundry list up here for LTSS specialists because the introduction of the new service was hard. And there is a primary model by which people get personal care now. And that's true across the country. Agency personal care is a primary waiver service that people receive when they're elders and people with disabilities. And so then when you try to offer a new model, right, with agency personal care, consumer interaction, and then this is another option altogether. And I think it's, you know, I think the conversation for you to have is where does this fit and how do we think about it? And how, when we start our conversation with the family about what someone needs, how do we make sure that this new service is recognized as a way that someone could receive personal care? And so these are really just prompts to say, you know, whatever your workflow is, where do I introduce this to make sure that I'm thinking about the new service as another way that we want to. And that just triggers for me, you know, one, when Jen and I used to work for the state where we were first working on evolving this model, you know, where to the state where family members weren't allowed to be paid caregivers and where participants had to leave their home if they wanted to get care from a family member. And at the time, my old aunt was taking care of my very old grandmother, and she made the decision to both keep working a full-time job and take care of my grandmother. She was never going to let my grandmother leave the home, and basically killed herself with, you know, wore herself out providing care around the clock. She would go to the hospital and be a nurse, and then she would come home and take care of my grandmother. And I have pictures of her before she started providing care to my grandmother and after, and you can see her age overnight from just the stress of caregiving. And she didn't have any other support. There was nobody else that she could turn to for help. She was too proud of her kid to be extra help. And I think that's the promise of this service that you guys will now have available to you, that there are family caregivers who will want to do this for a little bit of time or a lot of time. But to the extent that you can, I hate this expression, take advantage of it, make it possible for them to do what they want to do and what they're capable of doing. It's just another resource that's available to you, and it will take time for this service to sort of pick up and for people, for you to become comfortable with it, that it's a model that will provide sufficient support to caregivers. But there's so much information out there now about how families want to do this. They just need some support. They just need a little bit of support from state caregiving. But as long as they can do it, and as long as we can boost them up, give them somebody that they can vent to safely without feeling like, mom can get ripped away from them. The more we can do to keep them feeling supported, the longer they will provide caregiving, the more likely they are to say, I just need a break today. Is there somebody who can come in? Can you help me think about somebody who can come in and say, Mom, I'll just go take a walk. Yeah. This is really exciting. I think, other states are going to look at what South Dakota is doing and see, I know a lot of states where managed care is now, managed care is trying to figure out, how they continue to keep people in the community for as long as possible, and the resource that they are considering is family caregivers. And you guys are figuring out how to do that.
Always rates come last, right? Rates come last, and some technical language too. So we're gonna, these are, I would say, these are daily payment rates. These are established as they are per diem payment. So per participant within the home is to be a daily payment to the structured family caregiving provider per participant when they're enrolled with that caregiver in this program. The tier for which the payment is established by the LTSS specialist based off of the CHA assessment, the RUS score. Yep. And that provides the tier for any particular participant. I would also say that this is the total payment for the service. So this includes both the component for the provider payment and the caregiver stipend. So caregiver stipend is paid as a per day stipend as well. So a portion of this goes to the caregiver for the care and support that they provide, and a portion goes to the provider for the assessments, the ongoing communication through technology, through phone calls, for the home visits, the coaching that they provide as well. And we also use the word stipend purposefully as well. So we use the term stipend because this is in many states where we provide this service, this is established as an independent, say, contractor-like model where caregiver is contracting with a provider agency to provide care to the participant. They agree to communicate with that provider agency. They agree to, say, complete daily notes or regular notes for the provider agency to communicate what's happening in their home. They also agree to report, say, incidents that might occur, hospitalizations that might occur, and be responsive to, say, questions from the provider agency about how the participant and they are doing on any given day. Any provider can do this in any way, right? So we have other providers in other states that may do this as an employment model as well. So we're not here to recommend one way or another. We're just here to say we use the term stipend because it's a per day payment to the caregivers, so not say an hourly payment for the care specific to those hours. And I guess I would say as well that that when you are thinking about talking to participants or family caregivers about this service option, well, these are the rates that are established for the service. It's always awkward when the rate question comes up, right? Because you can't say that the full rate goes to the caregiver because there obviously has to go something goes to the provider. So some of that information will also come out through the supplemental agreement as well, how the state kind of thinks about what that will look like, what those stipends, what that mix might look like. I think I would say, in terms of the stipend as well, in other states, where we provide the service, we talk about the stipend and that it's tax-free slight payment. So this is for federal IRS, Section 131, stipends provided to caregivers who are providing care, living with a participant, and providing regular care This is more of a difficulty of care-like payment. So it's not a payment for a hired service worker who might be providing the service on an hourly basis. It's for someone who is committed to providing care to someone that they live with and support, and that it is done so through a service that is established by the state. So the state has identified this as for lack of a better word, a foster care-like payment. No one likes that term, foster care. It's that's how it's written in the IRS code. But what that does is make the payment to the caregiver, the stipend, tax-free for federal tax purposes.
So what I want to say about that is that a lot of that information may not be necessary for folks in the world, right? The key point there was, if engaging with families, you don't want to suggest to them that they might be getting $40 a day. Because when they then engage with an agency and the agency says that the stipend is another amount, it's created disappointment and really missed on expectations. And we can spend a whole bunch of time, talking about questions that providers on Skype may have about the structure of the model. We're happy to share how we do this in other states. I think key for people in the room is you've just heard about a new service. And one of the things that's really disappointing is if we spend a whole bunch of time on the development of a new service, getting a waiver amendment approved, and then there's no uptake of the service. So I think in part this forum, maybe now or maybe in a different forum, it would be great for you guys to sort of say out loud, these are the anxieties or concerns or the things that are coming up for us as we think about whether or not our staff would, think about using the service. If you don't want to have this available and then have no one use it. And I don't know that I have a great example of what an anxiety is, but it might be, what if the agency allows the caregiver, who we know to be engaging or not particularly engaged or, problematic, what if the agency started working with that caregiver? We have some concerns about that caregiver from our work with them so far. Those are the kind of things I would just put out there so that you don't, have the service sitting on the books and then don't use it. Is there anything that makes you anxious about it or causes concern? I mean, caregivers are caregivers, right? And as Jen said, they're going to be imperfect. Certainly, I would think that we wouldn't, if you had a concern about a caregiver, when you made a referral to a provider, you would share your concerns about that caregiver. Last time you went home, the daughter wasn't there, now she lives there, or, she wasn't engaged in the care, but she says she can do it. Those are the kinds of things that if you have that information, this only works if you share it, so that the provider can check in and make their own assessment about whether or not the daughter can really, is really prepared to do it.
Yeah. And not really providing any care.
Yeah.
And that moving a family,
Yeah.
But you don't get those
Yeah. I think that's really important to say out loud. I think it's critical to always like that to elephant in the room. So to that, I would say a couple things, right? You're going to qualify providers to provide this service. They're going to have to demonstrate in order to get enrolled that they have the capacity and have some experience in supporting family caregivers. Could ask them questions about what their assessment is. What's their assessment process of figuring out what a caregiver's motivation is for saying, I want to do this. And then the other thing I would say is you can look at those rates and see that if that's the per diem rate to an agency, and only a portion of that is going to the caregiver, we call it modest, and I think that's being polite, right? Now families will do in situation and tell their family member might say anything, right? I think you have to get to the place where you can trust that the provider organization is doing a really thorough assessment. It's not just big with their check. It's a conversation. It's do I think that they're going to provide the care? And they talk about how they've been providing the care so far. Can they show me that they know how to babysit mom? It's really interviewing an inquiry process to get to the place where, we're going to take on an imperfect caregiver, but we're not going to take on a caregiver who we think their motivations are not the right motivations. Yeah. And we understand the risk, right? We're all doing community services. Things go wrong, bad things happen. We should do it in the community, and we're trying to manage those things as best as possible. But yeah, that's why a portion of this rate is going to the provider, because you're paying them to do the right thing. You're paying them to do the assessment. You're paying them for ongoing coaching. And what could happen? A caregiver could start out doing it for the right reasons, and then, even if they do it for the right reasons, some things could change, and they can no longer be a caregiver who's appropriate for the model. In which case, they're no longer in this model anymore, right? The provider comes to you and says, this is not working, we need to work, we need to transition and practice to smarter services. You don't keep people in it, and, it's the work of that.
The provider has an experience with that.
So this is part of the reason why we have, the state can set minimal requirements about face-to-face visits or, yes, and monthly contacts. I can tell you that our organization, we're doing this in the state, we would have much more. In every state where we operate, the state sets a minimum bar, and we say we're going to have more physical contact than that. So in fact, in many states where we operate, we have daily contact. If we don't hear from, we're not working home every day. We don't get our staff helicopters. But we're having daily contact. For us, if we don't hear from a caregiver on one day, our red flag goes up, and if we don't hear them for 2 days, then we keep it. Yeah.
So like the electronic notification.
So EDV is a method that's used in home care, right? In this model, EDV doesn't extend to this model. We have just decided as a provider organization, and in other states where we work, other providers do the same thing. They just have a method of checking in that's more substantial than clocking in and clocking out. So if we don't get a note, or if we get the same note every day, then we know they just clocked it open the day before, but we're really making sure that daily we're checking in. I'm not saying that we don't do that here. I'm just saying you have to trust that a provider organization is doing the right thing to make sure that they're connecting with the caregiver. And if you phone call one day and text another day and drop in visit, the next month, providers for where are you going to be today? Maybe I'll meet you at the community center. You've got to be doing the right things to stay engaged with families to make sure that the care is being provided.
My biggest concern for the providers is number one, we've set up family members as employees for providers, and then so they go through all this work getting less than what I would consider really low income, and they don't have what to do for example on the APS situation.
Yeah. So this is where I would just say, again, I'm going to just from clearly experience, we spend a whole bunch of time up front before we bring somebody into the service. And I'm talking crassly now is somebody across from the state side to the provider side. The costs involved in finding the caregiver, qualifying the caregiver, setting them up with the caregiver, training them, orienting into the program. If you bring somebody into the program and you lose them 2 months later, you've lost a whole lot of money. And so that's why we're really cautious about, we want to support every caregiver that we possibly can, but we don't want to bring people in who will not be successful. So that's why we spend a lot of time up front. You know, we'd like to get people into service as soon as possible. We think that's best for making sure you don't lose them, right? You're not catching that. If you've lost them, there's a crisis, they're making a different decision that they will be here in your. So we like to get in as early as we possibly can, but we don't want to do so at the cost of, you know, engaging with the family and kind of false apart there.
Yeah. Don't just say, oh, we want to do this, what we want.
And you know, and we do it, it's not that I mean, it's like interview inquiry with people in the eye, you know, being in the space with them. So you guys are going to state's going to set the minimum criteria, and then I think provider organizations will figure out if they need to, you know, put some stuff on top of that.
We have a process by which we would do that, and that would be part of our normal process, right? We have to demonstrate it. And the first thing that people hear is people when they're here, you know, someone's just going to come in and say, are they take care of my mom? And they're going to say, okay, yes, what they want. That is not how this works. They actually are going to prefer that they have absolutely the ability to take care of them. They don't do something. They have struggles, and there's an agency there who's available to take the help and support and do it. It's people who will say, I will do it, who will never actually talk to them. Unfortunately, it's just, you might have to do it in them.
Is there a question or comment over here in the front row? I thought you were
My question is about frequency, and it's obviously based on the media.
Yeah. And I think, you know, in many states where we operate, the states have requirements that we're just importantly, like, required to be very engaged at the beginning and then, you know, allow you to moderate. Providers will do, you know, providers will want to do the right thing in terms of upfront, I need to make sure that I'm confident that this situation is there. We don't want to have it bounce back and be an unsuccessful placement. We're certainly not going to think about wanting to make a referral to us again if every time you make a referral to us, we bring somebody on service and then the next month we come back to you and say, oh, by the way, we're going to discharge the person of service. You know, it's not working for that. That doesn't do anybody any good.
Well, and the first step really is going to be through our intake process, the LGSS specialists doing their own assessment and saying, you know, I think this might work for this family. So that referral is going to come from us to the provider to begin with, and that might curb some of those concerns.
I remember when we first designed this service, Jen and I wrote the rules for another state, and I'm embarrassed to say now that they're like 40 pages. And really small font. Because I was a state staffer, and this was the first time that we were paying family members directly to do something, and, you know, trying to prove this point that people who could be served in facilities could be served at home by family members. And so we like put belts and suspenders and all these other restrictions in place. You know, made providers jump through a whole bunch of hurdles in order to be able to say that they could provide this service. Because I was just, what state staff and people are going to get hurt on my watch. That's really what I thought about, you know. But we needed to do something. We had way too many people in nursing homes, and there wasn't anything more we could do to shut down, you know, the front door of institutional settings. And so we really needed to take this big leap, this big risk, that we could, you know, create a model and have people be safely served. And, you know, it's not that I didn't have sleepless nights at first about it, but you have to take a leap if you're going to say, we're going to trust family members to do something, we're going to give them support. In this case, the state has done a great thing, right? It said we're going to have some structure around this. This is called structured family caregiving for a reason. The structure means we're not pushing family members out there and saying, good luck to you. We're saying we're going to give you some support to do that. Yeah, that's a good good service. So your assessment is going to identify the member has a need for, help with ADLs. And I think that's what a caregiver can do. And then I think other service, if there's nursing or other kinds of support, the family caregivers can actually do those things.
The only services that are part of structured family caregiving, so we can't add on, is homemaking, meals, and chore services. So any other services that we already have can be, based on a necessity, can be an add-on to the structured family service that's already being provided. No, it would be just like how we do it now. An outside provider would come in and provide that particular.
Is the employee under the structured family
Yeah, they work through the caregiver would be both.
Right.
Taking one along with the other. Yeah.
Just another person inside the home.
Right.
Right.
Right. Well, no. Yeah. Yeah. Yeah, we had that question come up yesterday around, can somebody, I don't know how my organization would think about that, but, a caregiver could be doing arguably could be doing something else, right? A provider who has to assess kind of if this is going to be left at home alone for any period of time. We work with, in some states where the caregiver isn't allowed to be outside the home working at all, and we work in other states where the state allows us to make an assessment that the caregiver can be out of the home for a period of time, volunteering, doing something else, visiting their dog, just getting out and about. You really need to have that assessment and that provider who's documenting what is happening in the home. Our contracts with caregivers obligate them, we have an agreement that they have to perform these specific activities. So they're signing their contract with us, which says, I'm going to do these services that are in the care. So it's very clear what they're supposed to do and what else is going to do. Then we're holding people for that. Right.
Well, if you were on what is there through the checks or the checks, they were not to be double. And we're supposed to be very kind of control then for this year, then 6 months. So we come in for a 6 month review, and I'm only under that. So I have to know for ever.
Definitely. I would say you should. What would I say? I would say that if we have been working with that family for an extended period of time, I want to first and foremost make sure that mom's personal care is being taken care of, and I have a higher tolerance for other environmental things, maybe not being in the best shape to get done. When I was caregiver for my kid, my whole journal is getting the kid when he went off to college, and wasn't in the house anymore. So, but I would think that that's exactly, if we've missed something, if your providers have missed something, then that's a conversation that needs to happen. Because you've provided eyes on, maybe we haven't been there, but maybe the provider actually hasn't done home visit for a period of time. So you've identified something. But what the state is doing here is putting the power of the structured family caregiving agency together with your eyes on in the home, and together that you're going to try to make this thing work. You've identified an issue, and we have to figure out what's going on. Maybe the caregiver has been super stressed by caregiving and they're not being able to get to, what they otherwise would take care of. And do you care if the grass is warm? No, maybe. But do you care if things are in the home and mom can't get around and, there's no food in the refrigerator? You bet you do.
You have to remember that maybe they're like,
Yeah. As I said, it was 40 pages of rules that we wrote. We definitely applied some, excuse my language, like white middle class girls set of, rules about sheets and towels and, box spring, and I'm embarrassed now, to even say I was developing a program for people from many different cultural communities, and I was applying my sort of lens for what that home needed to look like. And, I walk around with and I try not to do that. And now when we go to skates, we say, that was a mistake that we made, or it felt like the right thing to do at the time, right? And no, that's not true. Actually, they have. But it takes, right? That's what we have said to these guys is you're going to make a set of rules that are what you think are the right rules, and 2 years from now, you're going to say, we know a lot more now, what do we want to add and what do we want to take away?
Yeah, I think that's what's next.
all of these meals, like what's the services that are included within this are meals, homemade by and for, other things like respite, lamps, skilled nursing services, starting could be also brought into that home to help support that family member and caregiver. Here's the section that I talked about before, some of the guys not described about what that, how to classify, how we classify that segment. And then again, the amount of the portion that we go to the caregiver is still kind of under discussion at the stage, and how that will be articulated in something else over. But just like the Rachel said, to clarify that whole would be a portion of those statements and a portion of those statements. Yes, family members can provide this. Relatives who are already doing this work can enroll in this service or participate in this service. Minimum criteria certainly up front would be fingerprint background checks, and then I think anything beyond that we would try to work with them. We'll still see some groups out there what other criteria might be in there, but we have to obviously through the assessment process, being able to provide the care as dictated on the website of an LTSS care plan. Providers feel confident that the care can be provided at the times the participant needs it. So whatever say responsibilities the caregiver might have, first and foremost is the participant receiving the care they need. And finally, work outside the home. Again, I guess I go back to first and foremost, how are the needs of the participant doing that? These are the assessment needs, and how are they receiving those care needs throughout the day, and then what are the other responsibilities that our caregiver and the participant, the caregiver, the participant isn't assured the participant receives the care that they need, and then therefore that dictates whether or not the caregiver is able to say be outside home for a period of time. And we also assess that caregiver or participant, as Rachel said, to see even if they have dementia and they even be left alone for any period of time. So we're kind of doing that for all that upfront work.
I think the really key point in this question, Jen, is about the caregiver has to tell us about what they're doing or what they want to be doing outside of the home. So we're working with a new family in Pennsylvania this month, and this is the first time we're serving people in Pennsylvania. And it's a new relationship for us, but mom, who is taking care of her adult daughter with significant mental health issues, really just wants something. She's been doing it for a really long time, all by herself. She's very happy to have support and somebody to talk to. And she is starting to tell us that she has, a goal of being able to take some classes and to finish her education. And is she there yet and ready to do that yet? No. But she's let us know that, and I think we think it's our job to work with her to meet her goals, because if she's happy, then she's going to stay. She's doing a really hard part, taking care of a job with some really significant challenges. But if we can help her get to meeting part of her goal, she's going to stay caregiving for as long as she possibly can. And so, you know, if she said, I just want to do yoga once a week or something, whatever it is, I think it's really important over time to have caregivers tell you what it will help to let them, you know, just keep caregiving for as long as they can without losing their minds.
When you're talking about employment for that caregiver, we have a lot of laborers who come into our state and then they have work requirements. If they have to be employed by a certain amount of time after coming here, being a caregiver in this kind of setting, is that makes them any idea that is their requirements? Because right now they're not getting entitled on the provider.
So just let me make sure I understand the question. The work requirement attends to what? Their citizenship.
Yeah.
It's been a long time since I took my oath to become a citizen. I don't remember that work requirement. So what we would say, this is what we say. So how can I answer this? So I don't know the answer to that question. So I'll think about it and, you know, confer with you guys. Maybe you guys have an opinion about it. In other states that are now imposing work requirements as a condition of Medicaid eligibility, when we talk to those states, we say, this isn't paid employment, people aren't getting a W-2, they're not getting that. We make the case that this should meet that requirement. It's not work in the official sense of the word, but it should. It's our position that it should count towards such requirements.
That becomes one of those people experience in other areas, but, you know, it's a lot of nursing on families that we're talking about.
Oh, so it's about Medicaid.
Section.
That's a good question. Yeah, it's a good question.
Do any of the individuals on the Skype webinar have any questions? Feel free to type in the Q&A if so.
I feel like a family that like this system has been doing for years is not that it comes down to money. If you're with a family member that we already have set up with as a employee of the agency, they're going to say no. Yeah, we want this to keep up with the future. I feel like this is the Lord of the end that my family is supposed to and they don't get themselves into that space that happens.
And I think to have that conversation, I think you need some success stories that we can talk about and share with each other and, you know, take some experiences away from. I think, you know, part of the reason why Jen, you know, went through like an agency board is to say, this is not agency coming in and doing personal care and giving it, you know, back to staff and giving it doesn't want anybody else, you know, touching him. visitor agency that comes in to support you to do that. And so we do work with lots of families who have been doing this for years, and then we come in and we're just so happy to have somebody to help us. We're finding something that we can question of. So that's how families become receptive to something coming in. I'm coming in to support you, or I'm coming in to take this away from you, right? Because that's, I know how to do those better better. If you're going to keep being in this area, and we're going to help you out. I appreciate that. So is this helpful? Is this provide a form for you to share what's on your mind after all this hard work you guys did?
I'm going to go ahead and end the recording anyways.